Welcome to Nova Signal Academy, your source for education and training for sonographers and physicians. Today's presentation will be on vasomotor reserve testing, presented by Andrew Monk, Senior Clinical Specialist with Nova Signal's Medical Education Team. This course will provide you with a basic understanding of how to assess vasomotor reserve using transcranial Doppler ultrasound technology. The two types of exams we will cover are the most commonly used forms of TCD testing, the breath holding index, and the vasomotor reactivity with CO2. What is vasomotor reserve? It is the cerebral vascular system's capability to maintain consistent cerebral blood flow and autoregulate blood flow volume. Both changes in homeostasis and changes in perfusion pressure can affect cerebral blood flow. For this lecture, we will focus on the use of CO2 to elicit the cerebral blood flow response. When you combine changes in homeostasis and perfusion pressure, that's an assessment of changes in cerebral autoregulation, a separate form of cerebral blood flow assessment that will be covered in a lecture later to come. TCD pathway. When cerebral blood flow is critically reduced and causes a state of hypoperfusion, which is inadequate delivery of oxygen to body tissue caused by occurrences such as strokes or TIAs and vessel disease like moyamoya. Intracranial vessels are extremely sensitive to changes in blood gases, such as CO2. Changes in arterial gases leads to changes in vessel diameter, which leads to changes in cerebral blood flow. So we use TCD to help assess the cerebral blood flow response to this stimuli. Changes in inspired gas levels, so the air you are breathing in, causes changes in arterial gas levels. Examples would be hyperventilation, where you're taking in more oxygen, and breath holding, where you're retaining CO2. We can experimentally control arterial gases such as CO2 levels and monitor the intracranial vessel's response with TCD. What is TCD measuring? Vasomotor reserve is the percent change in cerebral blood flow in response to changes in CO2. So with TCD, we are measuring the intracranial vessel's capability to dilate and constrict to maintain balanced cerebral blood flow in response to changes in CO2 in the arterial blood. The three responses we look for are normocapnia, hypercapnia, and hypocapnia. The image below shows these three responses from left to right. The top waveforms show bilateral middle cerebral artery waveforms and the end-tidal CO2. What you can see from left to right is normal mean flow velocity that then increases with increased CO2, which then decreases with less CO2. What you also see in the image is the mean arterial pressure remaining relatively constant regardless of CO2 changes, showing the vessels are responding to homeostasis changes but not affecting perfusion pressure. What is normocapnia? It is the state in which arterial CO2 is normal. We expect to see normal vessel tone, normal vessel diameter and resistance, and normal cerebral blood flow velocities. Normal level of CO2 in blood is 35 to 45 millimeters of mercury. The image circled is representing a normal arterial vessel. Our second state of response is hypercapnia. Hypercapnia is a state in which arterial CO2 is increased. We expect to see vasodilation and decreased resistance, which leads to increased cerebral blood flow velocities. The image circled is displaying a hypercapnia response. Our final response is hypocapnia. Hypocapnia is a state in which arterial CO2 is decreased. We expect to see vasoconstriction and increased resistance, which leads to a decrease in cerebral blood flow velocities. The image circled is displaying a hypocapnia response, which you can see has a thicker vessel wall when compared to the previous two responses. Now that we know our general terminology and how CO2 affects cerebral blood flow, we can talk about the different TCD exams that are used to assess vasomotor reserve. The two most popular exams with TCD are breath holding index, or BHI, and vasomotor reactivity with administered CO2, or VMR. First, we'll cover breath holding index, which is the monitoring of cerebral mean flow velocities during normal capnia, or normal breathing, and hypercapnia, or breath holding. So how do we perform a BHI exam using TCD? First, we set up continuous bilateral monitoring probes to record the MCA's mean flow velocities and pulsatility index. We record baseline values for at least 2 minutes while the patient breathes in normal room air. After baseline recording is achieved, we instruct the patient to stop breathing or hold their breath after a normal breath. We do not want the patient to take in a deep breath, and we usually give the breath holding command during an exhale, so there is less oxygen present and the hypercapnia response can happen quicker. You can use a nose clip to help the patient hold their breath and help prevent them from breathing through their nose during this part of the exam. The breath hold should last a minimum of 20 seconds, but 30 seconds is more standard and would allow for a better hypercapnia response. Once the 30 seconds is up, instruct the patient to breathe normal again and wait to see their middle cerebral artery mean flow velocity to return to baseline values. What are we looking for in a breath holding index report? BHI values are calculated using a standard equation that can be seen here. A BHI of greater than 0.69 represents a normal cerebral vasodilatory response. Values less than 0.69 represent impaired CVR, and values less than 0.20 represent severely impaired CVR and high risk of cerebral ischemia. When your patient has impaired CVR, it means there is failure of collateral flow to maintain adequate cerebral perfusion in response to the hypercapnic challenge. Here we can see what a normal BHI exam would look like. We see both the left MCA on top and the right MCA on bottom. You can see a baseline of at least 2 minutes was obtained before the patient was asked to hold their breath for roughly 30 seconds. During the breath hold exercise, you can see increases in mean flow velocity in both vessels. You can also see how quickly the patient's mean flow velocities return to baseline values, which happened in about 20 seconds after the patient was instructed to breathe normal again. We calculated the BHI values for each side and can see both sides are over 0.69, representing this patient has a normal cerebral vasodilatory response in both MCAs. Another exam we will cover today is vasomotor reactivity with CO2, which is the monitoring of cerebral blood flow velocities during normal capnia, or normal breathing, and hypercapnia induced by administered CO2, and optionally, hypocapnia, or hyperventilation. So how do we perform a VMR exam using TCD? First, we set up continuous bilateral monitoring probes to record the MCA's mean flow velocities and pulsatility index. We record baseline values for at least 2 minutes while the patient breathes in normal room air. After baseline recording is achieved, we induce the hypercapnia response by administering CO2 gas mixture to the patient for 2 minutes and record values while instructing the patient to maintain a normal breathing rhythm. The CO2 gas mixture is often 5 to 8% CO2 increase from normal air. Breath holding is acceptable if CO2 gas mixture is not available. You would decrease the recording time back down to 30 seconds of breath hold. Once the 2-minute CO2 recording is achieved, you would pull away the gas mixture and instruct the patient to increase their breathing rhythm or hyperventilate with room air for another 2 minutes to induce the hypocapnia response. Once the 2-minute hyperventilation is over, you'd instruct your patient to return to their normal breathing rhythm and watch for the mean flow velocities to return to baseline values. What are we looking for in a VMR report? VMR values are calculated using a standard equation that can be seen here. A VMR percent change of more than 65% represents normal VMR. Values of less than 33% represent reduced VMR. Values less than 15% show exhausted VMR and high risk of cerebral ischemia. Values that land between 33 and 65% represent borderline impairment. Here we can see what a normal VMR exam would look like. We see both the left MCA on top and the right MCA on bottom. You can see a baseline of at least 2 minutes was obtained before the patient was asked to hold their breath to induce the hypercapnia response, which can be seen by the increase of mean flow velocities in both MCAs. After 30 seconds of breath hold, the patient was asked to perform 2 minutes of hyperventilation to induce the hypocapnia response. It's worth noting that the patient took just over 1 minute to return their mean flow velocities to baseline values. After calculation of the VMR percent change, we can see both values are over 65%, representing normal VMR. What does impaired vasomotor reserve look like? The image in the upper left shows how the left MCA responded well to the increase of CO2, where the right MCA's mean flow velocity showed little to no change. The image in the upper right shows that same outcome, but also shows how increasing the CO2 percent elicits a change in the healthy vessel, the left MCA, but the jump from 6% CO2 to 8% CO2 had no effect on the impaired vessel, the right MCA. It's worth noting that higher CO2 percent can elicit a faster and more intense hypercapnia response in healthy vessels. The bottom image shows a healthy vasomotor reserve response in both MCAs on the right side of the image versus impaired vasomotor reserve in both MCAs on the left side of the image. So impaired vasomotor reserve is represented as a lack of dynamic change in the insunated vessels, often MCAs, in response to changes in CO2. Treatment and management. Depending on pathology, treatment consists of blood pressure management, antiplatelets and anticoagulants, and surgical treatments. Increasing or maintaining the patient's blood pressure can prevent both symptoms and/or stroke from hyperperfusion. Antiplatelet therapy can help prevent progression of the disease, and surgical treatments such as stenting or bypassing the source can help prevent symptoms of exhausted vasomotor reserve. A common bypass would be the STA to MCA bypass surgery. Vasomotor reserve testing with TCD is a quick exam to help assess a patient's vasomotor reserve. Exams can be performed on both inpatients and outpatients, and does not require the use of drugs such as Diamox. This is important because drugs like Diamox have a washout period that can last up to 24 hours. This means your patient could have lingering effects from the drug for that period of time. With the TCD vasomotor reserve testing, once the patient's mean flow velocities return to baseline values, we do not expect any lingering effects from the testing past that point in time. So when should we use VHI testing? When the patient can cooperate with the breathing exercise, or when the facility does not have CO2 gas mixture available. When should you use VMR with CO2 testing? Mostly when the patient cannot cooperate with the breathing exercise. VMR with CO2 is a more environmentally controlled exam to look at vasomotor reserve with TCD. Again, both exams are great to use on inpatients and outpatients. Thank you for joining our presentation today. You can find more TCD presentations like this one at novasignal.com under Nova Signal Academy.